Hello and welcome to Seattle City Makers. I'm your host, Jon Scholes. Well, hello everybody and welcome to our latest episode. I am pleased to be joined by Dr. Elizabeth Wako, who serves as the CEO of Swedish Health Services. She has been in that role for just about a year and has had a 30-year career in healthcare. She immigrated with her family at 3 months old from Ethiopia, began her career as a registered nurse caring for psychiatric patients, went on to medical school in Utah, and completed her residency in anesthesiology at the University of Washington. She also holds an MBA from the University of Washington, and after a number of years on the clinical side of healthcare, including running the operating rooms at Harborview, our regional trauma center, moved into the business side and the administration side of healthcare, and today leads the 114-year-old institution up there on First Hill and with a presence throughout our region. And Dr. Wako and I talk about her journey in healthcare and career, her leadership at Swedish, the significant investment and construction that they have underway up on First Hill. We talk about her time running those operating rooms at Harborview, her first job, her strategy around dinner parties, and her perfect Saturday in Seattle. I hope you enjoy my conversation with the CEO of Swedish Health Services, Dr. Elizabeth Wako. Well, thank you for having us up to your office and making time for this.
Happy to.
I do love this vantage point of downtown. It's not one I've really seen often.
It is nice.
From the east here.
From all of those on Pill Hill.
Yeah.
Our view.
Yeah.
It's a nice view.
It's going to be changing to some degree, right, with all this. We'll get to that.
Yes,
you got a couple of construction
will.
projects.
I do. There's
around.
A couple holes surrounding me.
Yeah. So it's been almost a year, November 15th of last year, that you were officially named the present CEO here. What's been most rewarding? What's been most surprising?
Oh, wow.
And you served in the interim for a decent chunk of time.
Yeah, like 9 months.
Did it feel like a transition at all, or you just came to work the next day after being the permanent? It was the same as the day before?
It was. I just came to work the next day.
Did somebody put a balloon on your door or anything?
No,
like a sign?
Literally. There was nothing. There was no fanfare.
Were they more respectful to you?
No, definitely not. I woke up and the position was official and it didn't make any difference. That being said,
you got new business cards.
Oh yeah, you're right. I did.
Yeah.
I did get new business cards. I came into the role interim, acting like I was permanent. So it didn't really matter.
Yeah.
But it did make me feel good. So I was happy about it.
Is there something in these last 12 months that stands out to you as being most rewarding? I mean, you've been here a while, so that might be a hard
It is a hard
question to answer. But
most rewarding, or maybe even just rewarding. Well, so it is nice to be able to implement and prioritize things that are important to you. So that was nice. There were some projects I've been working on. I got to make some decisions and direct some of the care that we provide. So that felt good. What's different?
And you had opinions about that for coming in, into the role, I imagine, because you've been here for some time wearing other hats.
I've had opinions since 2011.
Yeah, it's not like you had to spend a year on a listening tour. Yeah.
No, definitely not a year on the listening tour. I've been with the organization for a long time, practicing as a physician, and as the chief medical officer, and as the chief operating officer, and as the chief exec. So I've been hanging out for a period of time. Okay, what I thought was really great was how excited my team was and the caregivers were. And I still will get people who will come up to me in the hallway and give me a hug and say, I'm so glad that you're our CEO. So that, I didn't expect that. And
somewhat surprising and rewarding.
It is, very much so. And then I've really enjoyed getting out in the community. So that's something that I didn't do as much before. So really understanding what's happening downtown, what's happening with the chamber, what's happening with DSA, engaging in a different way, having Swedish participate in many difficult conversations about healthcare and about our downtown. That's been really fun.
Because in your previous roles, you sort of had to be more head down.
Definitely. More operations, more, making sure we're making a margin, working on our caregivers, working on the care we're providing, keeping up our quality. And I'm doing all of that also. So that's still kind of running in the background.
Yeah.
It didn't go away.
Yeah, I got to imagine it's difficult to be in this line of work and to be connected and external and engaged with all the other things going on in this community, just given all the challenges that you face in healthcare today. And
it's true.
Labor, construction, the operating environment. We were talking about the shortage of IV fluids coming out of the pandemic, all of that. Like,
yes,
it's got to motivate or incentivize folks to really be head down.
It's easy. It's very easy to make your whole life healthcare because it will consume everything you give it. So it actually takes effort to pause and look outside. But we don't live in a vacuum. For us, it's the most important thing. But the reality is there's a whole world outside of it. And if we don't engage or understand that, it's really going to be hard to ensure that we build the services and I think the healthcare community that our community actually wants. So there's benefits, but the work we do is, I don't know, we're so lucky. It's inspiring. It fills your soul. You feel like you're making a difference. There's nothing better than healthcare.
Do you think we appreciate the quality of healthcare that we have in this community, that we have access to as residents in this community, and the choices, options, abundance relative to other places?
Not.
Yeah.
Absolutely
kind of take it for granted.
not.
All of this is up here on Pill Hill. And
we do. And, I even take it for granted. So my sister recently moved. She has lupus, pretty severe lupus. And we transitioned her care from West Virginia, which is where she was living, to here. And she went from seeing 2 physicians to seeing 6 different physicians managing her care. And the amount of changes that they made on her medications and her lupus regime, it was unbelievable. And I'm a physician. And while I told her, you really should move, there's better care here, I don't think I even realized how much better the care is. She is doing amazing.
Yeah. Yeah, we're pretty lucky.
Yeah.
I was reminded a couple weeks ago, a buddy of mine got in a pretty gnarly motorcycle wreck and ended up in the acute care unit at Harborview for a week or so. And it's pretty nice to be able to say, well, thankfully you're here and like you're in the best place possible after that. And you feel good with the care they're getting. And, he didn't want to be there, but I think he felt good with the care he's getting. And it's like, if bad things happen, you're in the best place possible.
You totally are. And Harborview is amazing, by the way.
And you had a tour of duty there,
did.
running the operating rooms and as an anesthesiologist.
Yes,
right? Yeah.
I did. And Harborview is absolutely the place to go for trauma. And it's a great hospital, I go back to Harborview and they still remember me. They asked me if how old my babies are, because I think I was pregnant the whole time I was at Harborview. So it's nice. It's a nice family.
Take us into like a shift or a day of running the operating rooms at Harborview. Like, what is that? What is that like?
It is hands down the most stressful job I've probably ever had. Like, you think this job is stressful? Try running the Harborview ERs.
So it gives you some perspective of sitting at the top of this massive organization as a CEO.
Yeah. It totally does, because the decisions that I make, nobody's going to die at the other end.
Here.
Here.
Yeah.
I mean, it will trickle down.
You could screw something up and
I can.
eventually get traced back to you.
There's time, and there's time to change your mind, right?
Yeah.
But when you're running the ORs at Harborview, which by default, it's like you get fallouts from the ED and from the interventional suites, it's challenging. Okay, so a day running the ORs at Harborview, so night shift, it was the worst. So I'll talk about night shift. The thing about running the ORs at Harborview is when you're an anesthesiologist, you are one anesthesiologist. There are 2 residents that are with you. Each of those residents can run a room on their own, and you can, support them, which means you can run 2 rooms. So what you're constantly juggling is what you're running. So I might be running like a finger replant or something, right? It's going to take 12 hours. So they'll do that in one room. So that room's taken. And then if there's a second room, then I'm making decisions about what's going to go in that room. So say, a kid comes in and they broke their arm. So I'm going to let them go in and do a quick fixture. But I really want that case to be relatively short, because what if a trauma comes in? So then the whole time you're sitting there thinking, I hope a trauma doesn't come in. I hope a trauma doesn't come in. But if a trauma does come in, then you still have to manage that, because you still have to care for that patient. So then I'll go in the room with the trauma, and call in another anesthesiologist who's 30 minutes out. So it's constantly like juggling what rooms can go and what rooms can't go, what cases we can do, what we have to delay on. It's decision making constantly. And it carries a certain amount of stress that is real. But it was fun.
When you stepped away from it, did you have sort of new perspective on running at that level for so long, of like that adrenaline, and then to be in a role where the adrenaline wasn't rushing through you as it was in that role? Did it?
Okay, well, yes. Well, so when I came to Swedish does some pretty complicated cases. And it's just not trauma, but the cases are pretty intense. And the thing about being an anesthesiologist is, what is it people say? Being an anesthesiologist is like 97% boredom with like, but 3% sheer terror. It's truly what it's like, because everything is generally going along really well. Mm-hmm. And then something turns, and then it turns a little bit more. And then you're like walking down a path you really don't want to be walking down. So there's you would have to engage pretty quickly. But I don't know. I think we like it. That the rush is it's good. And when you're good, you know that you're making a difference, and you know that in the end that patient is getting the best care they can, and it's the whole team. So it's never just you. There's other people to call in and support you.
And you're caring for patients and also teaching those residents at the same time. So,
yes,
yeah,
exactly.
I know that you made a decision early on in your life to go into healthcare as a nurse, and inspired by your mom's career as a nurse. I think you said in an interview with Seattle Medium that you, when you're senior year of high school, you're like, okay, I got to decide what I'm doing for the rest of my life. And you made that decision to pursue nursing school. Why'd you feel like you had to make a decision at that point around what you want to do for the rest of your life? I'm trying to think of like my thought process at 18. I didn't say I wanted to be I didn't even know what a downtown organization was, but I certainly didn't say I want to be a downtown CEO.
I don't know. I think maybe that's a little bit my parents.
Yeah.
And
a little bit of pressure.
Yes.
From them to you of like, figure it out.
Exactly. And, we were immigrants.
Yeah.
So while
you came over when you were 3 months?
Yeah, I came over at 3 months. But my parents came in their 20s. And so they, when you're immigrants and relatively early, so we immigrated from Ethiopia, there certainly weren't any other immigrants at the time that we came. So you don't really have a fallback system. You just have...
You didn't have other family here.
There's nobody, yeah.
Yeah.
So you really have to figure out, like, how am I going to ensure that the survival of myself and my children, right? And I think they probably imparted that on us quickly. So it's not just like you're going to go to college. It's what are you going to go to college for that's actually going to sustain you, and we know that you're going to be okay. So I think that was probably directed our choices a little bit more than maybe a degree in liberal arts. But nursing, it was easy. My mom was a nurse. She was amazing. And I knew she was amazing because, which is uncommon in nursing, people would come up to her. Like, we'd be out at a coffee shop and people would say, thank you for the care you provided, which is kind of...
That's pretty powerful.
Yeah. As a nurse, and granted, it was a smaller town, so it would be easier to recognize. This was in Walla Walla, yeah. And she won Nurse of the Year. So she was very inspirational. And I could see like her passion and her commitment and her desire to get up and go to work. Now, my father was a professor, and he had the same commitment, but it wasn't like...
Didn't get the same praise at the grocery store?
No.
Thank you for your wonderful teachings.
No, not quite the same. And I think it's probably maybe less instant gratification, right? Because if you're going to help somebody be a student, it's over time, and then maybe they'll come back to you 5-10 years later and say, well, you were a wonderful professor. But unlike nursing, where it really was today. So that was an easy decision to make.
You've got 4 kids. Are you applying the same pressure to them as they get older to figure it out sooner rather than later?
No, I'm not. I'm not a tiger mom. I probably should be, but I'm not. No.
Do they want to be hospital CEOs?
No.
Not a one.
No, not one of them. I don't know that they even really know what I do. So they know that
you had 2 of them at the fireside chat you did a few months ago at Seattle U, right?
Yeah.
They were in the audience.
Yeah.
Did they have a better 3 of them?
3 of them.
That's right, because your other was
Yeah, she's in college. So
Yeah.
she's finishing up her senior year. She's at Howard. But no, the three were there. I actually have a freshman, a junior, and a senior in high school.
Yeah.
Which is mind-boggling to me, considering I'm so young.
So they're going to have time to figure it out and probably not going to be CEOs of major healthcare institutions.
I don't know.
Or
you
maybe
never
they
know.
will.
Maybe.
Do you miss not being in the clinical setting, and what prompted your transition from being a nurse and a doctor running ORs to then getting onto the administrative side? And you went and got an MBA somewhere in there. But was there a moment or some inspiration
that made me flip over?
Yeah.
Yes, I would say. So I definitely did not envision that I would end up where I am now. When I was a nurse, I knew that I wanted to go to medical school, and I wanted to go to medical school because my sister, she was sick the whole time we were growing up, and my mom had constantly taken her to go see different physicians. And I remember my mom's a critical care nurse, so she has a good understanding of healthcare, and she would take my sister to different physicians, and they would tell her that she was overweight, and that was the reason why she was having the symptoms that she was having. And so when we moved to Walla Walla, my sister went to see a new physician, primary care doc, and that physician was the first physician who looked at my sister and said, "Oh, I think I know what's wrong with you." And she diagnosed my sister with Cushing's disease, which is a tumor on your pituitary gland that's constantly secreting steroids. And the steroids is what makes you overweight. And so all of her symptoms were associated with that, but nobody saw it outside of this physician. And I think that's what made me realize, I think, the difference that a physician makes. And so while I was in nursing school, I thought, you know what, I want to be able to do that. I want to be able to make a difference in people's lives in that way. So I went to medical school, did residency, did a fellowship, and was working as an anesthesiologist, kind of doing pre-op, meaning I set up preoperative clinics, the clinics that pre-op patients for surgery. So all of the stuff that needs to happen to optimize you so that your surgery will go well, that was the work that I did in addition to being an anesthesiologist in the OR. And I had an opportunity to go to a conference. And at the conference, there was a speaker who was speaking about a theory. I think he called it like upstreamist theory. And basically the theory is around this story. And the story is there's two friends, and they're walking up a hill, and there's a river on the side, and they hear a child crying for help from the river. And they look over the river, and there's a child that's drowning in the river. And so the one physician goes or the one friend goes and runs out into the river and, pulls the kid out of the water. And the second friend kind of walks up a little bit higher, and that second friend kind of grabs some logs and puts a raft together, because as they look up, they see that there's other children that are coming down the river. And the third friend just kind of leaves and walks up the hill, and the two of them say, "Well, where are you going? Why, we need to save these children." And the third friend says, "Well, I'm going to go up the river and see who's pushing the kids off the bridge." So that's kind of the upstreamist theory, is that, I was there, as an anesthesiologist, maybe pulling one person out of the river. And then maybe with my pre-op clinic, I could pull multiple kids out on a raft. But the reality is, why are these children falling off the bridge in the first place? And it's really understanding that. And that's the thing about administration that's different, is you really get to understand, like, what are the issues that are happening that cause people to have disease in the first place, and that cause these children to fall into the river. And you realize it's so much more than healthcare. It's about housing, it's about education, it's about food. It's so much more than we touch, but it affects everything that we do. And the way you can make a difference there is really by moving into an administrative role. And so that's how I found myself.
Further upstream. Yeah. What do you see as the major challenges facing healthcare in Washington State today? I heard a stat last week, and I don't know if this is true or not, you can help me verify it, but that hospitals in our state lost, I think it was $1.5 billion last year, thereabouts.
Yeah.
Sound about right?
It sounds about right. I don't think there's a single hospital in Washington State that made a margin.
Yeah.
It is incredibly challenging right now in healthcare. Coming out of COVID was difficult.
Mm-hmm. How so?
Well, there's challenges we have. So we don't have very many places to house our elderly or to house those that need care outside of the hospital. So we have patients that end up just living with us in the hospital, and it's uncompensated. So we're not receiving compensation for their stay. But at the same time, we can't just discharge them out in the community because they need some support or some help. So the lack of skilled nursing facilities, we're severely underbedded in this state. Our labor expenses are really high in this state, and that kind of weighs in also supply chain and supply costs have increased dramatically. And we continue to have supply chain issues that really haven't resolved itself post-COVID. And all of those increase your expenses to a level that, your revenue is just not able to match. We did get a win with the SNAP program and an increase in funding, which was the first time we had reached, like in 20 years, compensation that we've received for our Medicaid population hadn't changed. 20 years. So that's helped, and all of us are seeing a benefit from that. But then you still need to see your increased dollars from your Medicare and your payers. Mm-hmm. So it's challenging. It's hard.
And not a lot of control on the revenue side. It's not like other industries or businesses where let's launch a new X to drive revenue.
No, absolutely not.
Yeah.
And you feel an obligation to care for your community. So anybody who walks into the emergency room, we provide care for.
There's not like lines of business you easily can walk away from.
No, absolutely not. Yeah. It's not that simple. And other businesses don't deal with the same challenges, So like there isn't an Amazon website that you can go to and you're guaranteed everything free that comes in through that website. It doesn't work that way.
And despite all those challenges, you've got some major investments taking place up here on the hill. A couple holes in the ground, a couple tower cranes in the air.
Yes.
For those that aren't familiar with what you're building, what are you building and why?
So we are building what we call the North Tower. And the North Tower is an expansion, or really probably better said, a replacement of the First Hill campus. So the First Hill campus is the flagship campus, and it's quite large, provides a majority of the services. So we're replacing our operating rooms, our emergency rooms, and kind of interventional suites and new acuity adaptable beds, which means essentially that you can stay in the same room, whether you're an ICU patient to a floor patient. And,
So you come in rough shape, but you don't have to get moved around as you get better.
No, which is very nice. And you can receive your care continually with a care team that can support you. So the reason why we're doing the project is certainly because our ORs are from the 1960s, maybe even 1950s, so quite old. The building that they're under has seismic issues, so we want to be able to stabilize that. So it's essential. And our emergency rooms, oh my gosh, our rooms, those are also 1960s, 1950s. I'm sure if you've been to our First Hill campus, you've experienced the quite small rooms that need to be updated. And then we also want to be able to have behavioral health suites in our ED, which we don't have right now. And those are rooms that are, well, we do have, but we just don't have enough, that are safe for behavioral health patients when they come in. And, that's something that we're seeing more and more of in our population.
And what happens with the existing buildings where you're transitioning from?
Well, there was a component of the hospital that was old, and that part was already torn down, and the building is being built in that same spot. The rest of the hospital will continue to function. We'll remodel. Obviously, we'll have our old OR suites, and then we'll probably remodel and reuse that space for something different.
What's your timeline on these projects?
Fall of 27.
Yeah.
which is not that far away.
That it's a significant amount of development up here. I mean, how much of your time are you having to spend on that?
On this project?
On this project, yeah. Or do you feel
my
like,
gosh,
okay, now that ground's broken and it's underway, you can focus your attention on other things?
Yes. We have to prepare. So there's a fair amount of time and effort because it is a hospital. So it's not a simple move, so to speak, when you're thinking about moving clinical care. But a lot of it has been structured, built, designed already. By next fall, we imagine that the external structure will be up, and then we'll be building just from the inside out. So it's running on autopilot right now, and it's doing quite well. So far, we're under budget. Mortensen has been a great team, and it requires monitoring, obviously, and then kind of us constantly building our movement plans on the background.
Mm-hmm. In that Seattle University fireside chat conversation, I think you were asked a question about your leadership style approach, and you gave a response of proceed until apprehended. I think is what you said. Do I have it right?
It's right. My motto. It's my motto.
Your motto.
Yeah.
Say more. What do you mean?
By proceed until apprehended?
Yeah.
Okay. So a lot of times in life, I think people wait for somebody to give them permission to do things, or they ask, which only delays your ability to move forward and do whatever it is you feel like you want to do. This is almost along the same lines as ask for forgiveness instead of permission. Mm-hmm. That's very much my motto. And it's worked really well. I actually think everybody should have it as a motto, because generally, in your space what the right thing to do is. And if you are constantly, I think you're second guessing yourself when you're always asking for validation or other people's opinions about what you should or should not do. So really proceed until apprehended. That being said, I don't know if it's something that comes from being in the hospital, but at one point I thought, I don't even know where I got this phrase from, but I looked it up and it's attributed to Florence Nightingale.
Oh, really?
Yeah, which is wild and not surprising if you think about everything that she accomplished in her life. So if I get to carry the same motto as Florence Nightingale, I'm good with that.
Has it been your motto for some time?
Oh my gosh, for a long time. For a long time. I think I actually picked it up here at Swedish early on when I came in as a physician here.
Mm-hmm. Yeah. And do you try to drive it down?
Yeah.
Through the ranks in your team?
I tell my team that all the time.
Yeah.
All the time. And I'm, obviously I would be the one apprehending now.
You're the apprehender.
I'm the apprehender.
The chief apprehender.
Yeah. So, but I want them to feel empowered to make the right decision, and I trust them to make the right decision.
Yeah. And it seems like a value that's important in a massive institution and organization where there's lots of policies and procedures for good reason, but that can also slow a lot of things down. And so how you empower initiative and trusting intuition and conviction and encouraging and rewarding that seems important to getting big things done.
I think it absolutely is. And they know the policies and the procedures, and they know the guidelines. And they know about safe patient care, and they know about our quality and our excellence expectations better than I do. So how can I not trust their decision making?
You mentioned behavioral health earlier and how the new project will accommodate patients in that space more, and also you had a background as a nurse in behavioral health, right?
I did.
I was just before here at Valley City's treatment center over just down the street on the edge of Beacon Hill, and was learning and absorbing a lot around what they do and this new contract they have with the city of Seattle for some drug treatment beds up there. From where you sit in your experience previously as a nurse in this space and given your perch and perspective today, what do you make of this drug crisis, fentanyl crisis, the intersection with it and homelessness and mental health, and how we get out of it, how we make things better? And I'll just say my sort of takeaway from that visit and just the last several years is feels like we clearly don't have a medical system for what is a medical crisis. Do you see it that way? And what else is If so, what else is missing? Or do you see it completely differently as far as how we do better around this crisis in our community?
All right, Jon, you're killing me with these hard questions. This is a multifactorial problem that is huge, and I don't know that one component of healthcare or really our industry can solve the problem. I think everybody kind of has to pull their own weight. So how do I see it? So my background is behavioral health. I have worked both in inpatient psychiatric medicine, group family homes, home health. And so I have an idea, I guess, from that angle. And what I will say is our country really doesn't have enough support for behavioral health and any spectrum of behavioral health, honestly, from kind of those that are lightly touched versus those that are heavily touched with behavioral health issues. And we need to be able to both provide acute support and then kind of long-term residential support, and then kind of the home health component of it also. And if you can't manage the whole spectrum of care well, then I think you start to see the fallouts in all other aspects of it. And we have not invested enough in behavioral health. And the sad part is, even though we theoretically have mental health parity in our payers for receiving support, even those that are insured don't receive very good support for mental health issues. And then you throw in the stigma associated with mental health that I think leads to people being less willing to go out and seek services. And then even if you want to go seek services, it's very hard to find services or providers who are able to help you. So the ability, I think, to spiral to rock bottom in our country is, it's very easy. It's very easy. And if there's no safety net, then what do we expect the outcome to be? I mean, it probably looks exactly like it looks right now. So if we can't even catch those at the top of the spectrum, how are we going to catch those at the bottom of the spectrum?
Top being those with financial resources, private insurance. Yeah, it sure feels like this drug too, fentanyl, and the synthetic nature of it and the effect on people. The system, how we pay for things, hasn't caught up with it.
No,
one of the interesting things to take away from this visit was, they treat withdrawal, and it's a voluntary facility, and it's 3 to 5 days of that Medicaid will reimburse for withdrawal treatment. And the folks touring me were saying, well, the real effects of withdrawal from fentanyl don't really hit till day 5, 6, 7. So people are kind of coming in there, managing more minor symptoms of withdrawal, and then showing the door, and then they're back to dealing with the hard symptoms, and then likely back to using drugs.
Yeah, it's easy to slip back. It's fascinating to me. And fentanyl is new, relatively new. That being said, it's a very old drug in anesthesia. We've been using it for a long time. And I have to admit, I was quite shocked that it kind of came out of the medical world and started to be synthetically produced, because it's not necessarily a drug that works in a way that you would think it would be abused. Very short acting. But you can kind of imagine that something that is short acting will kind of create that constant drive for a high. And you're right, it's not 3 days is inadequate to really get somebody over their addiction.
Yeah,
and then it's not just the detox. Right, there's a whole psychological component to that and support that you need so that you don't automatically relapse. So it's a little, your thinking is quite short term if you think just detoxing somebody will address the issue.
Well, there's probably no elegant segue to this next question. James, our producer, was formerly in the news business, so he probably has one, but I don't. But I know in your spare time you like to plan dinner parties. And host dinner parties.
Yes, that's true. Where did you find that out from?
What is your approach to the perfect dinner party? Do you have like a philosophy and a way in which you go about hosting the perfect dinner party? because I have a lot of anxiety over hosting dinner parties because there's like so much pressure on you as the host of the menu, getting the right people there, the conversation, and then you have to get everybody to leave, like eventually.
That's so true.
So like, how do you approach your dinner parties?
Okay. Is there a right approach? Well, planning is useful.
Okay.
I don't think you need to spend a lot of time thinking about the right people. I think the right people.
You're not
are probably
over-engineering
the people.
it.
Yeah, I'm not over-engineering it. It's more like who's actually available.
Are you trying to introduce people that don't already know each other?
Sometimes I'll mix it up and throw somebody in who's a little bit different from the group. And, sometimes it goes well, sometimes it doesn't go so well, but it's always a fun night, I will say. The other thing is make whatever you want to make. Like, cook something that's fun and that's interesting. Don't finish everything before everybody comes.
Oh.
So you can go hide out.
You can escape for a little bit.
You can escape for
and
a
then
little
somebody
bit.
else can kind of assume the role of
like
entertainer
the hosting and keeping everybody in it. And it makes everybody else step up. And then you can get people to come in and help you. And then it becomes more interactive and more engaging than, just standing around and then sitting down. So if you can get people to come and help you.
So you're not seeking information on people's dietary restrictions in advance. You're just going for it.
I figure you need to tell me. That's on you.
Yeah.
But I will try and have a variety because there are I don't want to make it unsafe for anybody.
Yeah, you're proceeding until apprehended.
Yeah, I'm definitely. Yeah. You can see that works in my dinner parties too.
Yeah. And then how do you get people to leave?
Go to bed. I am a master, as my husband says, of the Irish exit.
You just disappear. Yeah.
Well, because you got to think, I've been going longer than everybody else, and I don't want them to, miss out on their fun. So
all good parties must come to an elegant conclusion.
Yeah. So I don't know, was that useful?
Yeah, I love the idea of the dinner party. I just never do it because I worry well, what if nobody comes or not enough people come? What if you don't have critical mass? But I guess a good dinner party can be had at any scale, right?
Yes. Yeah. Well, I mean, critical mass maybe is more important if you're like hosting a happy hour or a bigger event. But a dinner party is just a dinner party.
So I lie. We do a dinner party for our guests of the podcast. So you will get an invite to a dinner party in January with all the folks that have been on this last year. And I had a lot of anxiety over doing that the first time because I was like, what if we don't get enough people and people are busy? These are busy people. But we've done 2 because now we're in our 3rd season.
Are you cooking?
No. Ethan Stoll has cooked the last 2 at his restaurant. So, yeah.
Oh, well,
so
that's cheating right there.
I guess it's really not a dinner party. We're buying you dinner.
You're buying dinner.
Yeah.
And then the Irish exit really works then.
You just go blend in with the rest of the people in the restaurant and then ease out the back door.
Way out the back door.
But you'll be getting an invitation.
Well, I'm looking forward to it.
They've been fun. Yeah, they've been fun. What was your first job? This is one of our standard questions on our podcast that you got a paycheck for.
That I got a paycheck for.
Yeah.
All right. Don't laugh. Lee's famous fried chicken in Indiana. And I can tell you that what I learned from that job is I can tell you what's a breast and what's a thigh. Like super easy.
Yeah.
Really. Which is actually difficult once they're fried to know the difference between the two.
The shape takes a different form.
I don't know. There's just something now, I can tell like the little bits.
When were you in Indiana?
I lived in Fort Wayne, Indiana when I was in high school. So that was a high school job.
Okay.
I didn't last very long. I went to work as a waitress at, I think, Bob Evans, and that's where I really worked for a long time.
Were you frying the chicken?
No. I was picking it up and serving it out with the biscuit. And we didn't eat fried chicken, so I learned a lot about fried chicken and biscuits.
You didn't eat it even while working there?
I did, a little bit, but it's not my favorite.
You didn't grow up eating fried chicken?
No. But I have a good appreciation for fried food. But Bob Evans was the one that really got me addicted to fish and chips. Mm-hmm. Yeah, but our fish and chips out here is Ivers. It's pretty good.
Better than Indiana.
Yeah. Better than Indiana.
What's your perfect Saturday in Seattle? If you can design it from morning till evening. This is our second and final standard question.
Okay.
On Seattle City Makers.
I really wish I'd listened to everybody else's perfect Saturday.
But this is supposed to be
yours.
Your own. Yeah.
Okay, my perfect Saturday. Get up and hopefully sleep in, though I generally can't sleep in. But hey, it's my perfect Saturday. I slept in.
Yeah.
And I'd have an espresso, so my cup of coffee. If it was the perfect Saturday, I would send my husband to go.
It's the perfect Saturday.
To Il Forni to get probably the breakfast sandwich there, which is quite delicious. Then I would hang out on my porch for a little bit, on the deck actually for a little bit, and then hang out with the kids in the afternoon. And, even if it's the perfect Saturday, I'm still not going to control what they want to do because they'll, somebody will want to do something and I may or may not be interested, but if I want to hang out with them, then I'll do it. If they're all busy, I'd read something. And then, I don't know, go out with my friends maybe, do a couples thing, go out for drinks, go out to eat, go to, I don't know, Italian spinaci, Korean meat, and then come home and be in bed by 10 o'clock.
Love it. No dinner party on the perfect Saturday.
No, because then I would have to spend all afternoon prepping for it and, yeah.
It's great.
This is the lazy Saturday.
Yeah.
This isn't the doing anything Saturday.
Love it. Well, appreciate you making time for this and for what you do for Swedish and our community and your leadership in healthcare and serving people. And thanks for coming on Seattle City Makers.
Thanks for having me, Jon. It's been fun.
I hope you enjoyed my conversation with Dr. Wako. Really appreciate her making time to come on Seattle City Makers, and real grateful for her leadership of just an incredible institution in our region and in Seattle. And we are lucky to have leaders like her and healthcare systems like Swedish Health Services in our community. So thank you to her. And I got up after we chatted and visited with the construction team that is developing the two buildings there up on the hill, and it's a pretty impressive project and a lot to look forward to in more care and great health services that we have access to in our community when it's all said and done over the next couple of years. So great to see them expanding up on First Hill and investing in our city. I want to close out with a recommendation of something you got to check out in downtown Seattle, and I want to highlight the soon-to-open wine bar from Jamila Conley, who we've had on Seattle City Makers earlier this year, I think earlier this fall. I ran into her today, and she has an opening date for her wine bar bottle shop restaurant that will open on December 11th at 2nd and Stewart in the base of the Victoria Apartments. So go check out We Rise Wines on December 11th, opening date. It's a great addition to the retail core. I think it's just going to be a terrific space, and congratulations to her for her impending opening date here of the wine shop and restaurant. So congratulations, Jamila. Well, thanks everybody for joining us on this episode of Seattle City Makers, presented by the Downtown Seattle Association, with support from James Cito and production by Spark Creative.